The second part of this presentation involves showing you some slides on the stomach. I know this lecture is about the esophagus, but this will help you in the TBL session. The human parietal cell is an incredible machine. The normal stomach contains 1 billion parietal cells, and it is where acid secretion and production take place in the stomach. Helicobacter pylori is very common in developing countries, with up to 90% of populations infected. Children usually acquire infection between the ages of 2 and 8. In developed countries, it affects less people, around 40 to 50% above the age of 60, and around 20% less than the age of 40. So how do we diagnose and detect Helicobacter pylori? We have the invasive testing, which involves endoscopy. It's an invasive test. When we go in with a scope, we get a biopsy. We can send it for histology, and certain stains can show us the Helicobacter pylori. We can also do a test like the one you can see on the right side of the screen on a small tissue specimen of the stomach. We can put it here, and depending on the color change, we can detect Helicobacter pylori, or we can take it and culture it, which is very accurate, but it takes long time. Non-invasive testing include urea breath test, stool antigen test, and serology, which is the least helpful test. This is an example of how Helicobacter pylori is easy to diagnose. On standard gastric mucosal biopsy, you can see that we can use different stains, and we can detect the presence of this organism. This table summarizes the accuracy of testing for Helicobacter pylori infection. If you look at non-endoscopic methods or non-invasive methods, serology is the least accurate. UBT, urea breath testing that is, and fecal antigen testing are quite accurate. Endoscopic methods are more accurate, but they are invasive because they involve endoscopic procedure, be it by doing a rapid urease test or histology or culture. Infection with Helicobacter pylori has been associated with the development of gastric and non-gastric diseases, including cancers, ulcers, anemia, ITP, etc. Many antibiotics can be used for the eradication of Helicobacter pylori, but nowadays, with the development of resistance to antibiotics, the general trend is to use 3 antibiotics at the same time. Few words about peptic ulcer disease, and the material is all available in the handout. As in GERD, the pathophysiology revolves around the balance between protective factors and damaging factors. So what are the symptoms of peptic ulcer disease? Pain, often described as burning in character and usually located in the epigastrium. It's very important to mention that gastric ulcers and duodenal ulcers usually cannot be differentiated based on history alone. But in general, the pain occurs after meals, classically shortly after meals with gastric ulcers and 2 to 3 hours afterwards with duodenal ulcers. Also, food and antacids relieve the pain of duodenal ulcers but provide minimal relief of gastric ulcer pain. Peptic ulcer disease is usually diagnosed using endoscopic examination. In the past, barium contrast examination used to be done, but it is less sensitive compared to endoscopy in identification of peptic ulcerations and other mucosal lesions. Unlike endoscopy, barium studies do not allow the opportunity to obtain biopsy specimens from suspicious lesions or to examine for Helicobacter pylori. The demonstration of lesions suspicious for cancer on barium contrast examination often will require endoscopic evaluation for the confirmation and biopsy sampling. Complications of peptic ulcer disease include bleeding, perforation, and obstruction. This is an example of perforation of a duodenal ulcer. On the left aspect of the slide, you can see perforation. This is visible as air or a black bubble under the left diaphragm in the abdominal cavity. This can also be diagnosed accurately with a CT scan showing pneumoperitoneum. On the right side of the slide, you can see that if a peptic ulcer gets deep enough, it can hit a vessel and cause a major GI bleeding. On the left side, you will see in general the clinical manifestations of GI bleeding. Hematemesis is vomiting of bright red blood. Melanemesis is vomiting of blackish material. Melena is the passage of black tarry stools, while hematochezia is the passage of bright red blood per rectum. The treatment of choice of GI bleeding in the stomach or duodenum that is caused by a peptic ulcer that has eroded into a vessel is endoscopic therapy, and there are many modalities of using the endoscope to stop the bleeding. And finally, a few words about endoscopic ultrasonography. Endoscopic ultrasonography is a combination of endoscopic and ultrasound technologies to obtain high-resolution imaging of the GI wall and the adjacent structures. Endoscopic ultrasound provides the ability to obtain electronic dissection of the gut wall. If you look at the left aspect of the slide, you can see a white, black, and white layer. These would correspond on the right side to histologic layers, such as the mucosa, muscularis mucosa, submucosa, muscularis propria, and the serosa. This is an example of a small tumor in the esophageal wall that is detected by endoscopic ultrasound. If you look at the right side of the slide, you can see the tumor, and on the left side of the slide you can see the layers, the white black layer, and you can see exactly how much of these layers are being involved by the tumor. Hence, endoscopic ultrasound is a very important tool in the staging of esophageal and gastric malignancy. Tumors are staged based on the T and M staging. T involves the depth of the tumor and presence of lymph nodes, and M, distant metastasis. Endoscopic ultrasound is very important to determine the T stage and the N stage of these tumors in the esophagus and the stomach. We can use other imaging modalities such as CT, MRI, PET scan to determine the M stage. And it's very important to remember that staging is very important before deciding on the type of therapy to offer to a patient, such as chemotherapy, radiation therapy, and surgery.